Hey everyone, welcome. So, if you're a pathology trainee, you already know that clarity is king, right? Well, today, we are going to break down a really important tool that's designed to make our communication with oncologists absolutely seamless. We're talking about the new CAP template for quantitative IHC biomarker reporting.
All right, let's jump right in with a little thought experiment. Imagine you and a friend, a trainee over at another hospital, both get the exact same PDL1 case. Would your final reports look the same? Like word for word, format for format? Could an oncologist pick up both and understand them instantly, with no confusion? The answer is probably no. And that right there, that's the whole reason this template exists.
So here's what we're going to cover. First, we'll talk about why we even need to standardize our reports. Then, we'll introduce the CAP template itself, dig into some of the nitty-gritty details on specimens and specific biomarkers, and finally tie it all back to what matters most, improving patient care. Okay, Section 1, Standardizing Reporting. Look, the main issue here is something we call clinical variability. When every lab has its own way of reporting these complex biomarkers, it just creates confusion for the oncologists. And let's be real, this isn't just about making our report look pretty. This variability can actually affect which treatment a patient gets. The stakes are incredibly high. Just try to put yourself in an oncologist's shoes for a second. They need to look at our report and make a critical decision fast. If they're getting reports in 5 different formats from 5 different labs, they have to waste precious time just trying to figure out where the key information is. That opens the door to misinterpretation. And that lack of a universal standard? That is the exact problem the College of American Pathologists is tackling here.
Which brings us to the solution, the CAP template. To get rid of that confusion, CAP rolled out this standardized electronic template. And I want to be clear, this isn't just some friendly suggestion. It's a really solid framework built to bring some much-needed clarity and consistency to all of our IHC reporting.
And here it is in all its glory. We're looking at version 1.2.0.0. This thing is purpose-built for reporting quantitative IHC biomarkers in carcinoma. You can think of it as a master checklist, making sure that every single piece of critical data is not only captured, but presented in the exact same way every single time. No exceptions.
The official purpose really nails it. It's meant to be a generic and extensible framework. Now, what does that actually mean? Well, generic means it can be used for lots of different biomarkers. And extensible? That means it's future-proof. It can adapt as new biomarkers come along. Basically, it's about getting us all to speak the same language.
All right, moving on to a really important part, the specimen details. Before you even think about the results, the template makes you focus on the pre-analytical stuff. And I know, when you're busy, it can feel like just more boxes to check. But trust me, this data is the foundation that the entire accurate report is built on. It's not optional.
The template is going to ask you for things like cold ischemia time, how long that tissue is sitting out before it hit the formalin. It's also going to ask for the fixative you used and exactly how long it was fixed. So why do we care so much about this? Because every single one of these things can totally change how the IHC stain looks. Get them wrong, and your stain might not be reliable. It's that simple.
Okay, now for the main event. The biomarkers themselves. This is where the template really shines, especially with the complicated ones. We're going to walk through 2 big ones that you'll see all the time, PDL1 and the mismatch repair proteins.
Let's tackle PDL1 first. Now, you know as well as I do that PDL1 is tricky. It's not just one score. Depending on the tumor, depending on the drug, you've got different ways to score it. The beauty of the template is that it forces you, it makes you say exactly which scoring system you used. No ambiguity.
And look, here are the big ones. The template has separate spots for each metric. You've got your tumor proportion score, or TPS. That's just the tumor cells. Then you have the combined positive score, or CPS, which includes immune cells too. And there are others as well. The point is, you have to report them distinctly. An oncologist should never have to guess which one you mean. It's precision, baked right in.
And let's just double-click on that TPS versus CPS thing for a sec. It is so important to get this right. TPS looks only at tumor cells. CPS looks at tumor cells and immune cells. Why does that matter? Because the guidelines for a multi-million-dollar immunotherapy drug might hinge on a TPS score, while another might need a CPS score. Reporting the right one is everything.
All right, next up, mismatch repair, or MMR. This one's a different beast, right? The answer isn't in a single stain. It's all about the pattern, the relationship between a whole panel of 4 proteins. And you can probably guess, this is another spot where things can get confusing if everyone's not on the same page.
So here's how the template handles it. It gives you these clean, standardized interpretations. It forces you to think in pairs. You see loss of MLH1, you expect to see loss of PMS2. Loss of MSH2, you expect MSH6 to be gone too. It even covers the weird ones, like an isolated loss of just PMS2 or MSH6. What this does is take all the guesswork out of it. You follow the logic, and you arrive at a clear, standard conclusion every time.
So, let's land the plane here. What's the bottom line? What does all this standardization actually mean for you as a trainee? And way more importantly, what does it mean for the patient?
Look, if you start using this template now, early in your career, you're not just filling out a form. You're building a habit of being incredibly precise and clear. It means your reports will be rock solid, easy for the clinical team to understand, and consistent with a report from any other pathologist in the country. You are directly helping your clinical colleagues make the absolute best decisions for their patients. That's a huge deal. This template is, without a doubt, a massive leap forward for us right now. But it does make you think, doesn't it? It leaves us with one final big question. With things like digital pathology and AI analysis coming on so strong, what's the next evolution of reporting going to look like? How do we keep this same level of clarity and precision when the technology itself is changing under our feet? Something to think about.